Hello again and welcome back to the Calcium Masterclass, brought to you by Shockwave and Optima Education. Today we bring you Class 11, Dispelling the Myths of Nodular Calcium. As with previous classes, feel free to message us directly in the chat box at the side of the video player, and we'll do our best to answer your questions during the broadcast.
Our live case today is from St George's Hospital here in London, operated by Margaret McEntegart and Claudia Cosgrove. Moderated here in the studio by myself and James, as well as our special guests who have flown over from the US, Ziad Ali and Rob Riley.
But before our live case, we have a couple of presentations. Ziad will be dispelling the myths of nodular calcium with clinical evidence. And to get things started, let's go to Rob to tell us what is nodular calcium and why does it matter? Rob, over to you.
Fantastic. Well, thanks so much, James. Thanks to the Optima crew for having us out here. So we're going to spend a little bit of time talking about calcified nodules and why they matter when we do PCI. So calcified nodules are unique in that they have a morphology that's characterized by a bunch of small, dense fragments or nodules that protrude into the lumen, definition of a nodule. There are these two unique histological types. One is the eruptive type, where there's small, dense fragments or nodules that protrude with a fibrous cap that's got a disruption that can have associated thrombus with it. The other is a more nodular type, where you have a smooth, intact fibrous cap. That distinction is going to be important when we talk about how they can contribute to ACS later in the talk. This is what we look for when we talk about nodular calcium. So on the left, there's the angiogram that shows it, relatively classic nodule, as you can see right there. Intravascular imaging, again, relatively classic morphologies, as you can see in the middle on OCT, and then on the right side there with IVUS. On the right side, you see that big eruptive area with a bunch of shadowing in the back, showing you that dense calcium associated, and then in the middle, again, a relatively characteristic appearance there on OCT. In terms of the pathogenesis, how we think, again, this is all just theory, but what we have is we have an area where there's fragmentation of plates and sheets of calcium, and these tend to occur at areas of increased torsional stress. So we have calcium sheets that sort of form in the classic type on either side, but then the side where there's a bunch of torsion, you really can't have that sheet, right, because of all the torsion. So what happens is instead of a sheet, you have this nodule that forms at that side of torsional stress. There's a necrotic core that's often associated with these area compared to the adjacent regions, and that's where you can have that thin cap that can either actually erode and give you those ACS lesions or become more calcific and more chronic. And again, it's going to be flanked proximally and distally by these hard collagen-rich calcium, and that's going to be important later when we talk about how IVL can actually help address these types of lesions. Again, not surprisingly, you see the distribution there, all three epicardial vessels being more common in the more proximal parts of the vessels. We often think of them in the mid-proximal RCAs and the ostial circumflexes, just because those tend to give us the most problems. Again, they do account for some parts of ACS, and we talked about those two histological types and how that actually forms. And then there's worse short and long-term outcomes following PCI. Again, very similar to calcified lesions in general, but particular for nodules as well. Our traditional methods of treating calcium are going to be very similar for our calcific lesions and our nodules. Unfortunately, specialty balloons, whether they be NC, cutting, et cetera, again, they're meant to expand away from the problem at hand. They're going to go to the area of least resistance, really not treating the issue at hand, which is the nodular heavily calcified segment. Very similar with atherectomy. With nodules, traditionally, we used to always try and use stiff wires or different things to bias the burr or the crown over towards that area. But it's really hard to have a predictive ability to do that associated with all the other things with atherectomy that can be problematic, whether it's side branch loss, distal embolization, et cetera. So these traditional methods really, again, don't address the problem at hand with calcified lesions in general. And then it's really that much worse with calcified nodules. When we do look at uses of atherectomy, unfortunately, atherectomy does not close that gap in major adverse event rates for calcified nodules versus non-nodular lesions. You can see even when atherectomy is used here, those deltas are still quite high, major adverse events, and then all of the different parts of the major adverse events, whether it's need for revascularization, stent failure, et cetera. Again, another study showing the same thing. Unfortunately, even when the old traditional calcium modification tools are used, we still just can't close that gap with nodules. And this is an example of really what we're trying to avoid, right? For a long time, this is what we had. We have a big calcified nodule in the distal left main that goes into the proxial ADs. You can see there. You can see there even with calcium modification, stent implantation, when we run our IVUS back down, we really have a poor MSA, right? We just don't have good stent expansion, and that poor MSA is going to be predictive of worse short and long-term outcomes. Unfortunately, as you can see here on the left side here, we have that defect filling the ostium, as you can see on the left side there. Again, because of that poor MSA, illustrated on OCT, as you can see on the right side here, showing reprotrusion of that nodule into the lumen there, causing the stent failure in the patient to present back with an acute coronary syndrome. Now, the lucky thing for calcified lesions is that they are often associated with big calcific arcs. And this is really important because, as we know, shockwave works really well the bigger the arc. And so that is one mechanism where we think IVL really should work. This is actually borne out when we look at the Disrupt 1 through 4 pooled outcomes. We saw that IVL was actually able to close that gap between lesions associated with calcified nodules and without. And that was actually recently published with Dr. Ali as the lead author. And so this gives us some hope for the future of treatment of these lesions, that we're finally got a technology that's able to close that gap. And the reason for that is that we get good stent expansion. So what we'll see is that there's going to be a couple of different stent expansion modalities that we'll see. You will see modification of the nodule in about a third of the cases, where you'll get good concentric stent expansion and get a good MSA. And we'll see some where the nodule is less deformed, and we'll see this in some of the cases we go over, but you still get that good MSA. And what this really shows, this is what we've learned in some other things like subintimal tracking and things, that while it may not always be concentric, it's really, as long as we get a good MSA, we can really achieve those good short and long-term outcomes. So I wanted to show a few cases just to illustrate some of these principles during everyday practice. So this is a 73-year-old gentleman with end-stage renal disease, so obviously is set up for a lot of calcium. Recently had come in with an acute coronary syndrome, found to have an EF moderately depressed at 30%, and had 3-vessel coronary disease. He had actually already underwent staged left main bifurcation stenting a couple of weeks prior and came back in for staged intervention of his RCA. As you can see here, there's a mid-body lesion there in a relatively tortuous vessel, although the angiogram, you really don't necessarily see that there's going to be a lot of problems. But of course, when we run the IVUS catheter down, as you can see on the right side there, what we see is a nodule that crops up, and actually a relatively heavy nodule there. Again, we were able to get the IVUS catheter down, so there's no reason that we can't get our IVL catheter down. We took a 1-to-1 size 3.5 IVL balloon in there, went up and down the nodule, got really good expansion of the balloon, ended up going in with a stent after showing calcium fracture, as you can see on the middle there. And then as the IVUS runs through, as you can see on the right side there, we get deformation of the nodule and really good concentric expansion of the stent with an MSA over 8, which we know from predictive models is going to give this patient really good short and long-term outcomes. This is a second case of a patient who had previously undergone CABG, who had failure of an SVG to this OM. Lima to LAD was still patent, and the dominant RCA still looked relatively good. The patient had unfortunately developed severe aortic stenosis and was planned to getting TAVR at another center. The patient had been referred to me because the patient had developed some angina along with their other symptoms, and there was concern that some of the angina might be actually coming from the circumflex, and they wanted me to revascularize his circ prior to getting TAVR at the other center. So we go down and we protect both branches, and we run the IVUS through, and sure enough, there's a large nodule associated, as you can see there, that crops up just right around at 1 or 2 o'clock. Once we saw that nodule, we were actually able to take the IVL balloon down a 4.0. It's about a 4.0 to 4.5 vessel. And you can see on the left side, the nodule protruding into the balloon, but roughly after 60 to 70 pulses, as you can see in the middle there, the balloon actually gets really nice expansion. Again, planning on a provisional bifurcation strategy here. Sometimes when the vessel's a bit bigger than the IVL balloon, we go for that field effect. I ended up taking a larger NC balloon after the IVL balloon here, getting really good expansion, as you can see on the right. We then went ahead with stenting, provisional bifurcation technique with the inferior OM there. And this is an interesting case where you don't necessarily have concentric expansion at the site. You can see here's the distal vessel. You really got a really good MSA there. But then when we come to the nodule, you see that there's not the deformation that we saw in the first case, but still with a really good MSA. And again, this is predictive of the patient having really good long-term outcomes there. Here's a third case. It was a bit of a challenging case. Ended up coming in as an inferior STEMI when a partner was on call. As you can see there, the inflow, there's a really big left main nodule that protrudes into the bifurcation there. Unfortunately, ended up just treating the dominant circumflex with a single stent, a 225 long stent, and left the distal left main. The patient was transported to the ICU, and there was a somewhat abbreviated heart team approach where the surgeons came in and said, this guy's 83, he's got distal left main disease, you should probably proceed with PCI, which is when my team was consulted. We came in and had him on the books for the next day, but unfortunately the patient had recurrence of chest pain and then ST elevation, so was brought down relatively emergently. I was able to come down, reshot, and of course, there's end-stent restenosis, right? Because we have really bad inflow disease that wasn't treated, along with probably an undersized stent there. Unfortunately, we were able to rewire the circ, but really could not get anything around to try and get plain old balloon angioplasty to the stent where there was stenosis. So ended up having to actually wire down the LAD in order to shave the nodule just to get any gear delivered into the circumflex. Took a 1.5 burr down to shave the nodule. Finally able to get some balloons out to get some of the thrombus out of the circumflex stents. And then, of course, we took our IVUS down, able to look into that distal left main bifurcation from both the LAD back and the circumflex back, and look at how underexpanded those circumflex stents were. And of course, there's a huge nodule that protrudes. And even after atherectomy, big nodule, which again just illustrates how atherectomy unfortunately does not necessarily change the characteristics of the nodule that's going to allow us to get a good MSA and stent result. So after that, we ended up taking, the thought was, okay, well, we've taken rotational atherectomy down. NC balloons, unfortunately, still did not expand, and the Wolverine didn't cut it. And I was hoping we would pause for laughter, but we don't really have any of that. So we then took, the Wolverine cut it. So then we took the 1-to-1 sized IVL balloon of 4.0 up through there, and we were able to get fractures. You can see IVUS on the right. Finally, we were able to then get the stents in the circumflex expanded well, and then stent the left main and get a good angiographic result with a really good MSA, as you can see there. Again, though, the nodule did not deform like it did in the first case, very similar to the second case, but still with that really good MSA. So in summary, calcified nodules represent a very unique plaque morphology. They are associated often with severe calcium in plates, proximally and distally, which is really good, again, because that allows our shockwave to work in ways that other technologies can't. There really are limitations of the older technologies that we've sort of talked about, and IVL seems to address some of these limitations to provide similar outcomes for those with and without calcified nodules that we just haven't seen with other technologies. Thank you guys very much.
Rob, that was great. I think it's very interesting when we look at these topics, and the more we deep dive, we seem to almost miss the fact that in many cases we see all different types of calcium. How does that influence how you treat these patients?
Yeah, back before we had intravascular lithotripsy, there was the whole idea of, oh, well, do I have eccentric, concentric, do I have nodular, and that really might influence. But then when we really go through the data, we see that we don't actually create much of a delta with some of our older calcium treatment modalities that have been around for a bit. And I think the nice part is now that we have IVL, we've seen, oh gosh, there really are that many more different types of calcium. And do I need these different modalities? What's been so nice with IVL is that we've seen it doesn't matter if it's concentric, eccentric, nodular. IVL really seems to close that gap between those calcified, non-calcified lesions, like nodular versus non-nodular. So I really think understanding that they often do come together, right? It's usually not just a nodule in isolation, though it does occur. It's usually with that calcium, the sort of eccentric, concentric on either side, and being able to have a treatment modality that really addresses all of it is really key.
But do you think, if you see nodular calcium, does it put you in high alert? Does it make you think, uh-oh?
Yeah, we certainly, that's the area where we have less data, right? And so it's not definitive at this point. There is not definitive data that this is the way we need to go. It's certainly an area that's in active research. Do we need atherectomy first in some instances, then IVL? Is just IVL okay? It definitely puts you on high alert. And I think that's where maybe I'm going to use an NC more often afterwards before my stent implant to make sure everything's okay. But it's definitely a really interesting area of active investigation right now.
So now that Rob has helped us with a deeper understanding of nodular calcium, it's over to Ziad to dispel the myths of nodular calcium with clinical evidence. So Ziad, it's over to you.
Thanks a lot, John. So I'm going to be talking to you about IVL and calcified nodules And I think this is an interesting journey that we've been working on for the past couple of years, really learning and along the way dispelling myths and creating more questions. So the background for calcified nodules are that they account for about 5 to 7% of acute coronary thrombosis. We know that patients with calcified nodules have worse short and longer term outcomes following PCI. It doesn't really matter which outcome you look at. If you look at major adverse cardiovascular events, patients with calcified nodules do significantly worse than those without. And that translates not only from target lesion revascularization, but also cardiac death, clinically driven target lesion revascularization, and importantly, stent thrombosis. So obviously, calcified nodules are an important part of our need to understand so we can treat them better. So let's go back to the definition and pathogenesis. So calcified nodules are characterized by dense fragments or protrusions of calcification that project into the lumen. There are two histological types. First is nodular calcification, where the protrusion of the dense calcium has a smooth, intact fibrous cap. The second is an eruptive calcified nodule, where small, dense fragments or nodules of calcium with a fibrous cap disruption and luminal thrombus are present. So essentially what's different between these two is protruding nodule is smooth and it's got a cap on top of it, but an eruptive nodule is biologically active, kind of like a volcano, and bursts into the artery and is quite active and thrombogenic. Now, if we look about some of the details at calcified nodules, what do we know? We know that they occur at sites of increased torsional stress, and this is because calcified plates, the more there is an accentuation between diastole and systole, can actually lead up to calcium sheet fracture. We also know that they happen at areas of large necrotic core, and that's because as the necrotic core gets larger, or as there's a large area of lipid that allows the formation of necrotic core, we tend to get more calcification. And as evidenced by this, they're flanked proximally and distally by large calcium burdens. So generally, you have about 4 times the magnitude of calcification in and around calcified nodules. So it exists within a large segment of calcification. So what do we know? We know that they're located at areas of torsional stress and large plaque burden. That's the proximal or mid-right coronary, the proximal to mid-left anterior descending, and the proximal circumflex. This proximal disease is a characteristic that is fundamental of the large blood vessel size, which allows a large accumulation of lipid. The large accumulation of lipid acts like a nidus for necrotic core, and that necrotic core actually acts as a nidus for the formation of calcified nodules and calcium in its own. This is just another way to look at it. Again, you'll notice that calcified nodules are focused around the proximal to mid vessels and really happen in areas with large plaque burden. So, as depicted on this cartoon, you can see that calcified nodules happen in areas of torsional stress, have large necrotic core, and critically are flanked proximally and distally by these large collagen-rich calcium burden areas. Let's go into a little bit about the different types of calcified nodules. So let's talk about eruptive calcified nodules first. So what you're seeing here is a large sheet of calcium that's in an area with accentuation between systole and diastole where the calcium sheet actually breaks. As that calcium sheet breaks, it will actually protrude into the lumen and become thrombogenic. At the same time, the calcium fragments that are within the wall create an intraplaque hemorrhage, and as that intraplaque hemorrhage grows, it actually leads to a stenosis. So, eruptive calcified nodules occur at sites of increased torsional stress. They have a high prevalence of necrotic core calcium. They're flanked by these large areas of calcium proximal and distally, but they are believed to result from the eruptive fragmentation of sheet calcium. We know that these eruptions lead to ACS, specifically eruptive calcified nodules, and that's because as the sheet protrudes into the lumen, these calcified crystals are highly thrombogenic, and platelet reactivity on top of these nodules can lead to thrombus and acute coronary syndromes. On the contrary, a protruding calcified nodule has a different pathogenesis. Here you can see in this cartoon, what's happening is over time, the calcium is actually being pushed into the lumen by an underlying lipidic core or lipidic disease. So if you think of this, what happens is a calcified nodule forms. As the vessel positive remodels, the lipid actually pushes the nodule into the vessel. Another possibility for the pathogenesis of protruding calcified nodules is actually just the simple progression of the necrotic core over time into a large calcified nodule. And so there are fundamental differences between calcium that is on top of a lipid base and calcium that is on top of a calcified base. Now, protruding calcified nodules are hard, they protrude into the lumen, and they can often be very deep. And this has critical impact for stent expansion, eccentricity, and symmetry, as well as overall minimal stent area. Here's the problem. We cannot distinguish angiographically whether a protruding calcified nodule is on a lipid base or whether it's simply a progression of calcification. And unfortunately, we can't distinguish this by intravascular imaging as well. It does, however, have critical clinical implications because the behavior of these nodules is completely different. Well, can intravascular imaging help us? Certainly, optical coherence tomography can help us differentiate between an eruptive calcified nodule and a protruding nodule, but intravascular imaging cannot help us determine whether we're on a lipid base or a calcified base, and that's because we're unable to see beneath the shadows. On IVUS, the calcium reflects the ultrasound so that we can't see it behind it. And on OCT, the calcium is often so thick or on a lipid base that leads to signal attenuation and we can't see. So here's the rules of calcified nodules. You should consider eruptive calcified nodules are active, aka being associated to acute coronary syndromes, and protruding calcified nodules are passive. They've been there a while, they're obstructive, and usually lead to stable coronary syndromes. Now let's think a little bit about understanding plaque biology. So what is your lesion preparation strategy for this very proximal calcified nodule? How can we determine? The way we can determine this is actually the deformability. What you'll notice is that both on OCT and IVUS we have a protruding calcified nodule, and in the top X-ray what you're able to see is simply a non-compliant balloon is deforming this nodule and pushing it out of the way without any lesion preparation at all. And following this, very quickly, a stent expands and beautifully shows full expansion. And this is because this is an eruptive calcified nodule that's on top of either a lipid or blood base. And you can see that a baseline to post-PCI without any lesion preparation actually can happen very, very quickly. And that's the final angiogram of a case that took only the span of about 10 minutes. So understanding the deformability of these nodules is critically important to how we treat them. Now, here's an example of a deformable nodule. You can see on device detection a very large calcified nodule that's being pushed completely by the balloon. The wire is in the middle of the vessel, so you can see that the balloon expansion is concentric. However, a similar calcified nodule shows a completely eccentric expansion. The wire is basically abutting onto the calcified nodule, and this nodule is non-deformable. The deformability of the nodule thus dictates our further management strategies. So if we look for an example at an eruptive calcified nodule that's deformable, you can think of this like broken glass that's inside of a pillow. You can push this broken glass like as if it was to break on your kitchen counter. You just sweep it out of the way. And once you place a stent on top of it, the broken glass will be pushed away. So eruptive calcified nodules are often deformable, biologically active, and you can push the shards of glass back into the intraplaque hemorrhage. Now, protruding calcified nodules are slightly different. And right now on this OCT, we're not able to see what's underneath this, whether it's a lipid or a calcified base. The way, of course, we can determine, as I showed you, is the behavior of the balloon. And what the balloon will do is allow us to determine whether we can push the nodule into this lipidic base. And if we are able to, what we end up with is a concentric and symmetric expansion. Unfortunately, as I mentioned to you, sometimes we are not able to determine whether this is a protruding nodule on top of lipid or a protruding nodule on top of calcium. And here's an example of a marble on top of a rock. This is an entirely calcified base. When we try to inflate and push the balloon, it barely moves. And finally, when we place a stent, you see a very eccentric stent expansion with a modest but reasonable improvement in the minimal stent area. So what are some of the challenges that we face when we face calcified nodules? One, of course, is the ability to determine whether it's eruptive or protruding. The second is, of course, the different treatment modalities for nodular calcification all have different pros and cons. Now let's start with balloon-based strategies. Of course, because calcified nodules by nature are eccentric, we can actually inflate a balloon and look like we have complete balloon expansion, but you're only seeing the balloon on one axis. The second part, of course, is this eccentric balloon dilation can lead to fibrous tissue tears at the interface of the fibrous and calcium tissue, but of course not modify the calcium at all. And this can lead to a very eccentric D-shaped stent, and as we saw earlier, patients with calcified nodules have a significantly higher risk of stent thrombosis. And this is the character of what we can see would happen. We could be fooled into thinking this balloon is completely expanded, place a stent, and end up with a small minimal stent area. I think right now the dogma has been that atherectomy is the treatment of choice for treatment of calcified nodules. But of course, one of the problems here is that calcified nodules treatment by atherectomy is entirely dependent upon wire bias. And if the wire is not biasing into the nodule, actually the atherectomy can simply slip right by the nodule and not create any debulking whatsoever. Now the other thing to remember, of course, is that even if you do have wire bias, the amount of debulking is actually very small. This is a 1.5 millimeter burr. We know that nodules happen in vessels with large reference vessel diameters as a result of them being in the proximal vessel with large necrotic cores. And hence, the amount of debulking that we're actually getting by using atherectomy is really very modest, somewhere in the range of 10 to 15% of the nodule itself. So if we put this in perspective, look at the size of the OCT catheter, think about the size of an orbital atherectomy even with orbiting, which we'll get to 1.8 millimeters, and a rotational atherectomy burr that's most often used for atherectomy at 1.5, we're really creating very, very little impact on this calcified nodule. And while the conviction among interventional cardiologists is that we make this huge hole by creating atherectomy, which is going to allow this beautiful debulking and fracture and ultimately lead to this beautifully concentric, symmetric stent expansion, which pushes the nodule out of the way, the reality is that the amount of debulking we're getting is really very small. We don't image afterwards, which means we end up with substandard, asymmetric, eccentric, and small minimal stent areas. Put together, if we think of a protruding calcified nodule like a mountain or a hill, atherectomy will basically cut the top of the mountain off. But what intravascular lithotripsy can do, and I think this is critically important, is it can actually lead to multiple fractures within the nodule itself, eventually leading to crumbling of this mountain to the point at which it's modified and now deformable. And so if we look at this, what you're able to see is that the atherectomy may lead to a very odd-shaped stent expansion, and why the IVL is completely not perfect, what we can see is that by being able to make these small calcium fragments into pebbles or smaller fragments, we can push them out of the way much more easily. We all know the mechanism of action of intravascular lithotripsy, which is wire bias independent and provides circumferential calcium modification, which is critically important when we have nodules which are typically eccentric. And we also know that intravascular lithotripsy creates fractures in multiple planes, X, Z, and Y axis. And so what we're actually doing is creating small chips as well as creating fractures, which completely changes the compliance of this vessel compared to a non-compliant balloon, which typically creates only a single fracture in the axial plane. So the way to think of this is really like crumbling a plate compared to breaking a plate. There are a number of advantages of intravascular lithotripsy. Of course, there's no dependence on hydrostatic pressure. It selectively targets calcium. We're able to modify deep calcium. It's independent of wire bias. It's independent of lumen size. And in totality, compared to balloon-based strategies as well as atherectomy, you see IVL has a number of advantages to treat this relatively specific and clinically relevant area of calcium modification. Now let's jump to the data which has just been published. So this is hot off the press in JACC Interventions, our recent study which looked at the pooled data of almost 250 patients who underwent OCT guided PCI in the Disrupt CAD 1 to 4 cohorts. Of course, as we showed previously, you'll notice that the location of the calcified nodules is more prominent in the right coronary artery and LAD with a small number in the circumflex. We showed this earlier that in the right coronary artery, typically in the mid and proximal segments, we have a high proportion. The second highest proportion is in the actually in the left anterior descending, and then finally in the circumflex in the proximal vessel. Now, if we go ahead and look at the details of these patient characteristics, what you'll notice is that patients who have calcified lesions typically have a smaller diameter stenosis. And the reason, of course, is, as we talked about earlier, this happens in larger vessels. Proximal vessels have a higher or larger RVD, the diameter stenosis is less, and that's why we can easily be fooled into complete balloon expansion, especially if we're eccentric. You'll also notice on the intravascular imaging outcomes that the calcified nodules tend to have a smaller calcium angle and a slightly lower calcium thickness in a single view, and as a result, you may be fooled into thinking these are easier to treat than they are. What did we learn? We learned that the number of patients with adjacent calcium was extremely high, and that most patients had concentric calcium around the nodule, 60%, and 35% have 180 to 270 degrees. Why is that relevant? It's very relevant because these are larger arteries, and if you use atherectomy, you may not modify these segments of calcification which are biased away. And of course, IVL doesn't have that problem. Using large balloons can modify calcium in multiple different directions. So here's the meat of the story, and that is that despite whether or not there was a calcified nodule in the lesion, the minimal lumen area, minimal stent area, and mean stent area in patients with calcified nodules compared to non-calcified nodules was actually very similar. And we look at stent expansion at the maximum calcified segment and the mean stent expansion, there was no difference between the two groups. This is the first clinical data available which shows that any calcium modification technology actually has equivalent outcomes whether or not there is the presence of a calcified nodule. Earlier, my colleague and friend Rob Riley showed you significantly worse outcomes in patients with calcified nodules that underwent atherectomy. So there is this important data coupled with the 2-year clinical data which shows no significant difference in major adverse cardiovascular events, which is of course very promising. So how can IVL actually help? Well, of course, if we go back to this example, IVL may not be able to further crack or broken glass already. So in eruptive calcified nodules, the relevance or the benefit of IVL remains to be determined. However, in patients with eruptive nodules, we did show that the use of IVL in Disrupt CD4 led to very, very large acute luminal gains and excellent deformability with stent expansion. So the acute results with IVL were really very good. What we also learned that IVL worked very effective in deformable calcified nodules, presumably by the impact of fracturing these larger calcified segments into smaller pebbles, which then become much more akin to deforming and compressing into the artery wall. Sort of like filling a glass with a series of pebbles rather than with a rock. You'll have less spillage of the liquid. Similarly, in Disrupt CD4 cohort, we showed very clearly that patients with nodular calcification were able to have significant improvements in acute luminal gain and stent expansion. Now, we also have to worry about these protruding calcified nodules and what the potential impact of IVL is in these patients. The potential impact, of course, is to create fractures into the nodule, which may be able to break the calcium into smaller fragments and push it out further, improving compressibility and improving vascular compliance. When we look at these patients who have nodular calcification that were non-deformable with eccentric expansion, we did see eccentric expansion and asymmetry, but very good minimal lumen areas. So overall, it's important to remember that we got 34% of patients who had deformed eruptive calcified nodules, 43% of deformed nodular calcification, and only 23% of patients had eccentric expansion with non-deformed nodular calcification. So in English, what that essentially means to us is that almost 80% of calcified nodules that were treated with IVL were either deformable or became deformable, leading to excellent stent expansion. And this is a really important message to take home. So almost 80% of calcified nodules treated with IVL had evidence of deformation with concentric expansion. This is new data and probably supports why there is excellent minimal stent areas acutely and also no difference in the long-term clinical outcome of these patients at 2 years. So if you recall, the rules of calcified nodules are eruptive calcified nodules are active and protruding calcified nodules are passive. We know that we have calcium fractures in multiple planes. We know that IVL aids in the deformation of calcified nodules, and we know that IVL gives us consistent minimum stent area and stent expansions. We'll finish off with a very quick case of an example of a patient with a calcified nodule in the proximal left anterior descending. What you can see on the OCT is a clear presence of a calcified nodule, and following intravascular lithotripsy, you see significant fracture of this nodule into multiple planes and a complete disruption of the nodule compared to the way it was in the preoperative OCT. And as a result, what we do is we have compressibility, deformation, excellent stent expansion in this very hard to treat patient population and lesion subtype. And if we just compare the pre-PCI to the interval and post-PCI, it actually highlights critically how the mechanism of IVL works. You'll see that after IVL, the minimal lumen area only increases a little bit, and that's because it's modified the calcium at very low atmospheric pressure without creating tears, but it facilitates stent expansion to the point at which we are having almost a quadrupling of the minimal lumen area. So, in summary, IVL is clearly the therapy with the lowest learning curve. It's extremely safe. It has less restrictions than the clinical environment. It's sized to the vessel for optimal use, and there's very encouraging early data to show both acute procedural results and the minimal stent area. And on the right side, what I've done is I've highlighted how the calcium algorithms need to be changed to incorporate IVL amongst the other modalities, perhaps even as the first line, given it is the only modality with strong clinical evidence to show acute and long-term results in patients with calcified nodules. Thank you very much.
Thank you, Ziad. I mean, that's a spectacular talk. I'm going to challenge you straight away because rotational atherectomy still is the most widely used therapy for nodular calcification, especially in left main disease. The argument that you're making here, shaving off the top of the mountain with small caliber rotational atherectomy, surely what you're making the argument for is just larger caliber atherectomy devices to shave off the whole mountain.
You're absolutely right, John, but we have to remember that even if you go from a 1.5 millimeter burr to a 2 millimeter burr, you might change your debulking from 11% to 17%. These calcified nodules are so thick and the calcium leads out so far, we really need something that can work on the rock base that we can't see. So typically what we'll do is we won't do a pre-dilation with a balloon before doing atherectomy because we don't want to disrupt and create dissections before. So the dogma has been that don't do any balloon dilation before you do atherectomy. And so what ends up happening is we use a small burr, we don't look at it, we use a balloon, see eccentric expansion with all the caveats that I explained in the balloon and stick in a stent. And then we said, oh, we blame it on the nodule. Oh, well, it's a nodule. IVL breaks the mountain into smaller rocks and eventually with enough shock into pebbles. And that allows you to push it out of the way. And I think it's really important that we understand this concept of deformability and compressibility when it comes to nodule rather than simply about compliance.
Okay, so you made the point about enough shocks. So what is enough shocks? If you've got one of those nodular calcium with calcium underneath, is it just more shocks that's required, or are those lesions you think are non-modifiable?
I think that's an excellent question. So I'll answer that in two parts. In calcified nodules, that is the one place where my power surge takes the vast majority of the pulses, maybe even all of them.
Yeah.
So I will actually use 70 to 80 or all the pulses into the calcified nodule because you're really trying to break that mountain into pebbles. So that's number one. The second thing is, I think we have to understand the limitations. There is some calcium that is simply too thick with the 50 atmospheres that we get with the current IVL technology to be able to fracture calcium. We know that iterations of this device may have greater energy. That greater energy may be able to penetrate through that calcium and fracture it. And I think that's what we need. We certainly haven't solved calcified nodules, but we've made a lot of progress. The striking thing about this, having studied this now, is that all of the clinical data to date, despite the fact that we used atherectomy all the time, is it's really poor. These patients do really poorly. This is the first data to show acutely and at the long term that you can modify acute procedural results and long-term clinical outcomes.
James, can I ask you, you've been one of the highest volume rotational atherectomy operators and probably now have done more IVL left main cases than almost anyone. What's been your experience as you've introduced it into your practice?
I mean, I think the points that Ziad made are very accurate in that if you want to modify a rock of calcium with a contact-dependent technology, you can only do that at the point it contacts.
Right.
And that's a non-modifiable weakness. And I think there's clearly still a role for rotational atherectomy. It's a fantastic device for particularly tight lesions. But when you get into the nuances and we start to talk about how to change wire bias, we need to be realistic. This is a technology that actually has not penetrated at all in 30 years, so a level of less than 10%. So there will be people out there who can change wire bias and get fantastic results from rotational atherectomy with very nuanced therapy. But in terms of dealing with the bigger problem, and we know nodular calcium is a big problem, it's not really ready for that. I think IVL, again, all the considerations that Ziad has made, the two important concepts, I think, for our audience to take away is this difference between vessel compliance, which is how bendy the artery is, and is particularly important when you want to deliver equipment, and particularly important for our colleagues and who are dealing with large bore access, where they actually want to go around twisty big arteries. But most of the time, the problem we're dealing with in the artery is compressibility. That's why soft plaque, we just squish it. So with calcium, actually, again, great analogy with the jar. You think of the jar that's never full. You put the pebbles in and it fills up the jar. Then you add sand and it fills up the jar even more. So the smaller these fractures and little pebbles of calcium, the more MSA we can get with our stent. So it may well be that we're heading in a direction that there isn't a point in which we say enough's enough. To get sufficient MSA, we may need more energy, we may need more pulses. What I can say is that we're moving in the right direction of understanding the problem.
Yeah.
So 5 years ago, we didn't understand the problem.
And I'd like to add one very important point to that we're all engaged in active investigation. Understanding the biology of a calcified nodule and how it forms, particularly from large burdens of necrotic core, it may be that a shave and shock or rotoshock approach may help modify. If you cut the top off of a mountain and the inside's actually a volcano, you're going to actually be able to break it with an IVL much, much better.
Right.
Those are areas that we don't have answers for, and we need to engage in clinical investigation like we are, where we're doing a direct comparison of a shave and shock approach compared to a shock alone approach. Because these technologies are synergistic. Mm-hmm. But what we definitely know is that IVL can break the rock into pebbles.
And we know that mechanistically, but we also do not want to start with a bias that this works or that works and there's no alternatives and so on. Therapy will be nuanced, just like coronary arteries are nuanced, just like patients are nuanced. We've seen today already massive heterogeneity within a single artery. So why should we expect the same consistency from the same application of a single therapy? So I think there's a lot of questions out there which are fascinating. I think it was an amazing talk, Ziad. Really,
thank you.
Really great to grasp that mechanistic nettle by the stem, if you like, and get into the nuances of it. But I think lots of answers already, but still more questions to ask.
And credit to Optima, because some of these concepts are really difficult, right? And being able to illustrate these in a meaningful way that people can associate to, I think can help them change the way they treat.
I like the mountain. It's my favourite new slide. I'm going to ask you a question, both of you, about C2+. So 120 pulses. Is it going to make a difference? Do we need more pulses? Do we need more power? Is it more power or more pulses or both?
Yeah, that's a tough one. We weren't saying actually too many pulses here. You know, it was as if you'd added another 50% to that, you'd have taken it. But again, there will be patients in which you don't need 120 pulses and so on. But you'd rather have it, particularly if you're not paying a price for it, whether that's a commercial price or a price in terms of side effects, which we don't seem to be any difference really. Mm-hmm. You'd rather have it and not need it than need it and not have it. Mm-hmm. And I think the challenges will be, how do you apply a single size balloon over a long segment?
Yes.
How do we deal with that particular problem? Do we oversize distally? Do we undersize proximally? It's probably going to be the former, isn't it? And how, you know, I think the biggest problem is, how do we assess whether the base of the pyramid of the nodule has been fractured?
Yeah.
How do we assess that in a single sitting? You know, that's still very, very difficult. And I don't see a way round of test, shock, test, shock, test, shock, test, this kind of loop, whether it's an imaging loop or it's a larger balloon loop.
Well, some of these the deep OCT is this new technology where you can actually see well into, you know, much deeper than you could before. With you've done quite a few of these cases.
Yeah, so the newer technology, deep OCT, can look a lot deeper. That penetration may help us being able to determine whether or not we've modified more deeper calcium. But this is just an unfortunate limitation of calcium with the two modalities we have for imaging. IVUS creates a reflection. OCT has deep signal attenuation the larger you go. So, you know, to sort of mention in terms of pulses, I think C2+ has a number of significant advantages, which is why we're desperately waiting to get in the US. Obviously, I have to come to you to use it.
Right.
And that is, it sort of takes away the nuances of pulse management. So here's a classic example, the Claudia case, right? What they're desperate to do is to fracture that undilatable lesion. Now you've inflated the balloon, a big balloon, in a big part of the vessel. But there's a calcified nodule that's 40 millimeters down. Now you've got a winged IVL balloon that you've got to get down to the distal vessel. If you have a large number of pulses, there's really no reason not to start distally, because you won't run out. You start distally, you deliver 20 or 30 pulses, you come back, you inflate your balloon, you see the wires in the middle, you're like, I don't need to shock that. Use device detection, look where the burden of calcium is on stent boost, deliver your shocks into that area, and use pulse management to your advantage with the additional pulses.
So now that we're up to speed with what nodular calcium is and some of the myths around it, it's time to put theory into practice by joining my good friend Margaret McEntegart, ably assisted by Claudia Cosgrove, who are now with us live in St George's Hospital here in London. We're going to go first to the PowerPoint presentation of the case by Novalia Sadiq, our interventional fellow. Novalia, can you hear us?
Yes. So our patient is an 89-year-old man. He presented with a non-STEMI last week with a small troponin rise. In terms of comorbidities, he had a previously medically managed non-STEMI in December. So this is his second presentation. He also has new AF, which was diagnosed as admission. He has hypertension and is relatively frail. His echocardiogram this admission showed an ejection fraction of 55% with a hypokinetic basal inferior wall. Hemoglobin is satisfactory at 117. He has mild CKD with an eGFR of 53. He's been started on treatment dose dalteparin as well as dual antiplatelet therapy for his AF. So this is his coronary angiogram, which was performed last week. He has a calcified proximal LAD disease. And also a CTO of his right coronary artery. So we'll go back to the live pictures just now.
So thanks, Novalia. That was very instructive. Looks like a tough case. Margaret, Claudia, we're with you now. Any thoughts on how you're going to take this forward? Looks like you've got a challenge on your hands there.
Thanks, James. Yes, so initially it's been a bit challenging to wire. We've got a microcatheter to support, just trying to get past this aneurysmal segment. You can see that it's diffusely diseased from the left main down to the mid-LAD with probably an eccentric shelf of calcium in the left main and then some potentially further nodular calcium further down, but the intracoronary imaging will clarify that. So we thought if I ever manage to wire this vessel, we'll pre-dilate with a small semi-compliant balloon and then start with an IVUS to determine the exact distribution of the calcium and then our calcium modification strategy based on that.
So it's one of these classic situations where you're concentrating on thinking about how you're going to deal with the calcium, and then you go to wire and you realize that, of course, there's a tight exit stenosis at that aneurysm. You see Claudia's hitting up against it there.
Yeah.
So she's had a Xion blue workhorse, and that wouldn't track across it. So she took a microcatheter in, and now she's got a Xion black. To see whether the kind of the coating on that will help it slip through, and just slightly stiffer to hold its shape a bit better as well as it crosses the aneurysm.
Yeah.
So hopefully we'll get down, and then you see that beyond that point there's actually a focal area where it looks like maybe angiographically it's suspicious of a small nodule, and it's also very tight there. So I think the microcatheter is a good idea just to support crossing that segment as well.
Yeah.
So Claudia, do you think you've exited yet?
Yeah, so I think I've gone past that first post-aneurysmal lesion, and now we're at the...
Looks like the wire position looks a bit funny though there.
Might be subintimal here.
Yeah, I'm not sure I like that very much.
You know, I really like Suo here because the heart can actually just push the Suo through the aneurysm for you.
That's it.
There you go.
There you go.
The only challenge
I
here
think
is
you're in
just
the
the
next
body
bin.
to get actually something across really tight.
Or you're maybe
heavily
going out that
calcified lesion
little
of the
diet.
aneurysm.
I think that's
Check.
subintimal.
Yeah, no, it's not subintimal, but it's out a small branch, I think.
Yeah, but it just check it's okay, and then if it's okay.
Yeah, I think it's out that.
Yeah.
See, there's a branch off that bend that wraps round.
There's no filling.
You know, the
So
other
you're
thing,
to the right of the calcium.
yeah.
So come back.
You have a huge septal in that aneurysm. And
Yeah.
so one thing, if you had a challenge, would be to actually wire the septal, take a dual lumen in,
Yeah.
and actually have the backup support to
Oh,
go
I see.
through so that you're not swirling
coming.
around in the
coming back.
aneurysm. It can just be a challenge, right? Because that thing can be
Yeah.
2, 3, 4x times
That's an
the
excellent
rest of the vessel.
Yeah, I agree, Rob. That's what I was going to
gosh.
suggest as well. A really big septal, and actually, as Margaret said, there's a very high-grade lesion immediately after the aneurysm. So it's trying to localize on that. It's pretty difficult with the wire floating about in it.
Yeah, it can be a real challenge. And you know, that's the hard part, is the black will allow you to get through something really tight there, but it won't give you the tactile feedback, and you certainly can get.
What
in
is
various
that
parts of the
wire?
architecture.
Is that
Cyan
some-
black.
It's
It's a
Cyan
on black.
Yeah.
Just let
Yeah.
that play.
The other question I was going to ask is that obviously this is a pretty hardcore case. The right coronary artery is dominant and occluded, but very short, very focal. Did you think about doing that first as a way of just giving you a bit of extra support from a hemodynamic perspective?
There you go.
There we
See,
go.
just changed the
There
view.
you go.
Well done.
Good work.
Yeah, James, it's a good question. And also we thought carefully about the collateralization, because obviously we're going to be doing calcium modification in LED. We might compromise perfusion to the right through the collaterals. But actually, if you look back through the films,
Cyan blue, right?
most of the collateralization is off the circ.
Yep.
So that's actually
Do you
quite
want to have more
helpful
of them?
for us. The septals are tiny and there's a huge AV circ to PLV collateral. So, and the circ looks good. We've got a wire in that, so we've got access to it. So we're less worried about the ischemic impact of what we're going to do in the LED.
Yeah, and I think we can see why the collaterals to the right from the LED aren't so good.
Yeah.
The LED's not in a happy place, is it? So
No. He's
But
getting a
it's
bit
really
ischemic
important.
just with the micro. That's the Cyan blue now. Changed.
Yeah, I think it's really important that you actually took the microcatheter down, not just from a wire switch out standpoint
Yep.
to get your workhorse, but also to give you a lot of information about the lesion. If you take that microcatheter down and it just sort of zips down, that gives you a lot of information as opposed to really having to work it down. That's going to give you more of a, gosh, I wonder if I do need to do some atherectomy up front, but it looked like it zipped down a bit okay. So
I thought it struggled a wee bit at the second
you?
lesion. I don't know
Yeah.
what you thought, Claudia. Was it easy to get across with that microcaster?
Yeah, no, it passed quite easily actually. Yeah, I mean there was a bit of resistance, but
So what are you thinking balloon size wise?
well, we've got a 2.5 balloon. I might try that.
A good test anyway.
Yeah. And then,
So tell us about your setup, guys. What do you have?
so we're 7 French right radial with a 7 French EBU 375 guide, and we've got 2 Cyan blue wires down now.
And
that's
given how
good, so
tight this lesion is, are you planning an upfront atherectomy, or are you going to try to balloon to make space for IVL?
Yeah, so our plan was to see if we can pass this semi-compliant balloon, and then if we can, we'll try to pass an IVUS, and then decide on our modification strategy from there.
So Claudia, if this balloon doesn't cross, what's your next balloon, or what's your next device?
Well,
balloon?
I think, yes, maybe a smaller balloon, and then if that doesn't cross, then we may be looking at
Swap out
rotational
for-
atherectomy.
Right.
Yeah.
Okay.
yeah, this is a case where I really like the 2.0 or 1.5 to carry balloons because they
Fantastic.
low profile and they just will not burst. I mean, it's actually quite difficult to do balloon-assisted microdissection with them because you get them up to 24 and you really have to work on them. But the small
Well done,
profile there,
well done.
that's actually quite nice. So moot point.
Okay, I think we're past, yeah.
Yeah, I mean, that tells you
Everything
as
you
much
need
as you
to
need to know, really, isn't it? I
Guides
guess
out little.
the other issue here
Broken
is,
the lesion and
I
anchored it in.
guess,
Yeah, there you go.
if you're thinking about guide extensions, is you might have to give up your
Yeah.
circumflex wire at
That's
some
true.
point.
Yeah.
But you could use a
We thought the osteum of the circumflex looked
Yeah.
unobstructed at the moment, but we certainly want to protect it.
don't wanna
And
get-
once
could
we
al-
stent back to the left main, it might.
We could always
is really good.
reinsert the wire.
It's all going up.
Yeah, good information.
So,
So,
I've basically stopped doing these type of cases without a guide extension for IVL, and I think one of the key reasons for that is pulse management. I mean, you've got a very long segment of calcified disease. You need to use your pulses
come back to
effectively
cranial
throughout
and-
the entire segment. And the IVL, the guide extender allows you to open. It actually allows you to do balloon-assisted tracking, and it allows you to focus on all the lesions throughout, maintaining your
look at
performance.
that.
There you go.
Yeah.
Okay.
That's fun.
Look at that. That's 18.
Yeah.
on the balloon.
Yeah, that's not going. Well, I mean, it's also good interventional practice, Ziad,
Yeah,
isn't
absolutely.
it, to have that?
Still not pop.
Not necessarily where you might have even thought you were going to dog bone just based on the angiogram compared to some of the other things.
And I guess the other thing about the setup that we didn't mention is you've got the Rampart
Yes, that's
radiation
normal.
protection in place as well, which is
Lovely.
great for the team to be able
Yep.
to work in essentially a radiation-free environment. Margaret, you're pretty much used to that in the US already now, aren't you?
Sorry, James, I missed that question.
Rampart and what it's done
Yeah.
for your interventional practice.
Yeah, so we've got two systems. So we've got two two rooms we use for the complex cases. So it just lives in those two rooms, and we've got really used to using it. It's great. You'll see we've both still got our lead on. I still I kind of I don't know. I think I feel even safer to have both levels of protection. And I'm lucky at the moment I haven't got any orthopedic issues, but I suppose if that was to happen, then I might change my mind about that. But certainly a lot of the guys in our place, you work without lead because they have had problems. And certainly on the kind of real-time radiation dosing, it seems very reassuring.
I've completely shed my lead at this point, and it's been
all right.
It's been honestly awesome. I mean, we were a bit, with the setup, and we finally did a STEMI with it in the middle of the night, and it was lovely. And it's just been, honestly, I feel so much different at the end of the day.
Yeah, well, you look different.
Yeah, you can tell.
Not in a good way.
No, I mean, it's the gray, but that's the children more than anything. Just trying to adapt. I'm just
adapting to the.
I'm really trying to sort of be present.
They've already converted me.
Just trying to be present.
What's your wire?
Yeah.
These kinds of cases, they have to say that just on repeat.
As far as it goes, I'll turn people everything in.
Nice. Very
Nice
good.
work.
Okay, good.
Well
Very
done.
good.
Nice.
Beautiful.
Okay, we're gonna go there.
This is an NC, is it?
A 3-0.
3-0.
Okay.
Yeah.
Okay.
The only thing I would say is that your NC balloons are significantly undersized proximally.
Yeah,
Yes.
yeah.
That's what
Claudia
we're
just made that point.
Sure.
Just have a look with the IVUS, and then we may need a bigger one.
Especially for the ostium of the LED.
Definitely.
Now let's
But
say,
I'm not sure you need that now, right? You've definitely cracked it. The wire's in the middle of the balloon. I think you could, probably stent here and then use a post balloon to size by MLD max of this, or IVUS 123 or whatever.
yeah. I mean, to your point though, then you have a scaffold in the way, and with a much bigger artery, I often will use that 1-to-1 NC, especially when my shockwave was a bit undersized. Personally,
it's a kind of pacifier, isn't it, in US terms?
100%.
It's there. We know the stent's going to go to that size, and maybe it's not required, but it does give you that
And
reassurance.
it's all the way down.
Pacifier.
Well, that's an American
So
term, isn't it?
if we
We call it a
got some,
dummy, but I thought you'd think I was talking about you.
No. Just today is a day of learning for me. This is really, this has been quite lovely.
so in the nodule on IVUS, what we should be looking for are two things. It's unlikely you fracture the middle of the nodule because it's just so thick.
Yeah.
But often what happens is you break the interface between the nodule and the calcium on the sides, so you should see a shadow or a dark gap at the sides of the nodule.
And we'll really be able to tell that post-stent IVUS run. That'll be the real telltale of what we actually did or didn't do.
The deformability.
Yeah.
Just a little bit beyond there would be nice if you could just show us the landing zone beyond.
Okay, see if you can go a tiny bit further. Yeah, we're just at the edge of that nodule.
Yeah.
And I always like to talk about what ifs with cases because I think they're really instructive.
Somebody
So
had
let's say
live
what
from the
if we
IVUS
couldn't have
room?
gotten the IVL down and we
you.
had to do atherectomy.
There we go.
Anybody have any issues?
Very
with
nice.
that?
Yeah,
here we
let's go there.
Stop looking any further.
Yeah. So that's a good landing zone there.
Yeah. We'll take that.
Yeah. Look at that though.
That'll push though.
It's certainly a well-chosen case for nodular calcium.
Absolutely.
Can you just fluoro
It's
and
like it
show
was
us where the
planned.
nodule is, Margaret? Can you show us where
acquisition.
that was?
Uneccentric now.
Fluoro and show
There's
us
a
where the
fracture.
nodule was?
Acquisition where you are on the
X-ray?
X-ray.
There you go.
Yeah,
Around that bend.
It was just
Yeah.
on that bend,
Yeah. Which, I mean, you called the ball, right away.
But like
That's
we were
a big
saying
set
before,
too.
look at all these different
Fractures.
morphologies
Yeah.
within a single lesion. You have eccentric calcium, you have nodular calcification, you have 360 degrees. I mean, there's really everything in here. Nice fractures.
Well, what I
And
think
And look at see the movement of the plates there with
Yeah.
all the fractures.
Yeah. What I think is interesting is a few years ago, we'd all been focusing on the concentric calcium, the proximal vessel, and ignoring everything else because
Nice
what are we
split.
going to do?
What are you going to do? Yeah, right.
Figure that out.
Let's pretend it's not there.
No, that's exactly. No, I got a stent in, so we're fine.
Yeah.
Yeah.
We've modified the osteum nicely.
Yeah.
I think it's all nicely modified.
Yeah.
Yeah.
You actually got a landing zone as well, which is ideal.
So I think it's just landing zone, yeah.
So what's the EEL in the proximal LAD? Just
You're going left main, I presume, here, are you?
Yeah.
It looked
it's
like.
just, is it, I think it's 4.5, isn't it?
Yeah.
Proximal LAD.
I mean, just talk us through that IVUS, Margaret, maybe while Claudia is
Okay.
working, just to show us the learning points for the audience and where you're going to go in terms of stent sizing, etc.
Okay. So you get IVUS full screen. Is that possible?
Yeah, it should be possible.
Even if you can't go full screen, we can see it well.
It's interesting, isn't it? The
Look at that nodule on the
know.
fluoro on the right.
Look at that.
Just a classic translucent.
Yeah.
Okay, got it?
Got
Yeah,
it.
we're there.
Got it. Yeah.
Okay, so here's the IVUS run after the 3O IVL and then 3O NC. So this is the distal landing zone. You see there's really no segment of this vessel that doesn't have disease. So we're going to try and pick a spot where there's as little plaque as possible to land on so we can ensure we get less than 50% plaque at the outflow. So we're thinking about somewhere about this region here, which is just beyond the most distal nodule. There's a nice spot there. So I'm going to bookmark that as our landing zone. We'll come back to that later for some
just measure
measurements.
can you measure the external elastic lamina there for me?
Sure.
Just give me an exact
3.0.
number.
Probably
Yeah,
There's the dots.
beautiful.
Yeah, great.
happy.
Very good.
So probably a 3.0, eh?
Yeah.
And you
With
see
the
we get
Boston, we
this
always
kind of
round down just a
eccentric,
little bit
slightly
compared to the-
nodular.
You don't have to with 60
protrusion here.
megahertz.
You do with a flag, though.
Yeah.
And then as we come up through the distal vessel, you see that most distal nodule up here at 2 o'clock, 2 o'clock.
Look at that.
And you just see it's
Fractures
calcified
there.
all the
Yeah.
way through this vessel with kind of multi-morphology. Some of it's nodular and protruding, like here.
Yeah.
Some of it's flat, thick, eccentric, and some of it's concentric. So the distal stuff's more nodular and eccentric, isn't it?
Yeah.
And then as we come up proximally, it becomes more concentric.
But
So
you
this
have
is the kind of
fractured the
aneurysm.
nodules, Margaret.
Yeah.
I think you've definitely. I mean, there's a change from the pre. There's no question.
Yeah.
Massive.
Lovely.
change.
Yeah, look at that.
That's where the concentric
So this is
was,
this concentric stuff, and you see a beautiful kind of movement of the broken plates here as we come through. So you see a lot more movement in the calcified plaque. See that there?
Top,
Yeah.
Almost floating. Eh?
Really nice. Yeah.
Great.
Yeah,
I mean,
so
they really see it
multiple
all. We see
fractures.
nodular, eccentric,
Yeah.
concentric. I mean, this case is really just a master class.
Pardon the pun.
Easy for you to say.
And you see we've got disruption down here
Yeah.
between 6 and 9 o'clock. So it's nicely modified
It's really
there.
nice.
And then we come to the ostium of the LED, which again, we were
More
keen to make sure we'd
concentric.
modified that. So let's have another look as we come out the ostium, and you see it's dramatically improved from the appearance at the start. So we've split it. We're going to be able to get a good, and we're probably going to land somewhere here in the body of the left main. So I'll give ourselves long enough area to do a decent pot because there's a caliber difference in the LED to the left main. So
Massive,
see,
isn't
we
it?
put our bookmark down here.
So
So
if
if
you-
we
if-
look at the entire length,
Yeah. Just map out 48 first, or that's
Yeah.
72.
so the full thing's 71. So what I'm going to do is look at where there's a significant change in caliber of the vessel. Sorry, for some reason that went double click.
What
So if
was
we
our
go
distal
back,
reference size?
3, Claudia.
Yeah.
3.0 distal,
Yeah.
so 348.
So if we guess,
Quite big there,
Likely.
isn't it?
big tube, that's the
Massive,
aneurysm bit, I think, isn't
Oh,
it?
Yeah, you'll have to cover
So say
that.
we go to there, and I measure that.
If you just click bookmark lengths at the bottom, Margaret, it says off at the
Yeah, this is
They'll do it for you.
okay. So there's, if we landed distal to the aneurysm with the first stent, we're looking at kind of 20, 32 kind of region. Or if we came more proximally,
yeah.
so it's about there.
Because you're going to be 1, 2, 3, 4.
So that's going to be 40. So if we took a 40, as you say, it's probably going to be about here.
Yeah.
Yeah. So I think we probably don't want to overlap at that kind of aneurysmal area. Would everybody agree with
that's
that?
Right. That's
Yeah,
right. You don't want
So
to
we
get
can
into it with that for
probably-
sure.
We can probably get across it with a 40 if we wanted to do that. But
I think
if
you
we
had your
take a
guide extension
3.0,
pretty far. You should be able to get that
What
48.
size is
48?
it approximately? Though?
That's the only thing that I wanted to make sure is we were able to
Yeah.
get that stent size up appropriately.
so we'd need a
5,
3.0
yeah.
that went to 4 or 5. So the other
Yeah,
argument is
you
we
can do
just
that.
stay distal to it and take a
That's
bigger
what I would
one if
do.
we've got enough length. Yeah.
I'd stay smaller
take a-
distally and then to go bigger proximally because it just gives you much
Yeah.
more dynamic range.
Yeah, I'm a little worried
Yeah.
about being able to get the stent to the appropriate size there more
And
proximally.
what does your left knee measure not? I mean, it looks getting on for 6. It's pretty big.
So as often as the case, it's ovoid. So it's probably back here somewhere, I guess. What about the thicker stent struts for nodular reperfusion? Does anybody think it reduces the risk of nodular reprotrusion, especially with eruptives?
I mean, it's a
It's
great
a-
question, isn't
Yeah.
it? I mean, who knows?
Yeah, but it's certainly a very important point to think about. And so I actually use the 3-cell connector cells stents in nodules just because I think I have an extra bit of metal that might
to hold
prevent
it back.
Well, but
Yeah.
that's the hypothesis.
But that's the mechanism
that I
of
was-
failure, right?
That I
I
was
think
sort
that
of
we
bringing
know.
up. Yeah.
We know that in eruptive calcification, the mechanism of failure is
3,5NC,
reprotrusion
just-
through the
go like this
struts.
if we can see that.
You must have seen it,
3515
Ziad, in some of
NC.
your OCT studies, that these fully expanded, fully treated nodules within a few months sometimes.
Yeah, we
grow
just
back
actually
incredibly
published the
quickly.
2-year data
Yeah.
in JACC Interventions. I think it should be out either this week or next. So eruptive calcified nodules have a 20% event year at 2 years, and non-eruptive calcified nodules have about 5%. And the mechanism of failure is the reprotrusion of these eruptions that go through the stent struts.
Yeah.
They're
Want to
thrombogenic.
test to see whether
They're flow limiting, and they happen at these sites of
Yeah.
torsional stress.
Let's go back a couple of
That was my question. Are they more common in
back a
certain
couple.
parts of the artery? That the reprotrusion.
back one.
We don't know. Akiko and
Yeah.
our group are working on an important
Yep.
study where we have seen in 12 patients that you stent the eruptive nodule, and then because you change the torsion in the artery to the next focal point just distal, the next nodule happens just distal to the stent edge.
Well, it's like
You
stent
just-
failure, isn't
Yeah,
it?
you just
Lovely example here.
Yeah,
of
just
pushing it
the-
along.
Of the expansion of the
It's long, isn't
stent. It was almost completely even along the length. There was a little bit of restriction in the at that nodular section.
Just a little bit, yeah.
And even just seeing
Yeah.
how the stent delivered.
Yeah.
I mean, think about what that vessel looked like before we got started.
Yeah,
Just
yeah.
Remember,
being able to
there's
deliver
no
much
atherectomy
stents
here.
like that is
Right?
No
This is-
atherectomy.
This is
Took
an
a
all
microscopy.
IVL
Take the
case.
3.5 and then
Yeah, use
I'm going to
that
take the guide extension out and then
Really
wire the
quick.
circ.
Yeah,
So
I mean,
you
that was
saw
the case.
Claudia.
What was the length of the stent? Is that a
That was
32.
32.
The 3030.
So
Really?
right?
you saw Claudia use a balloon, deliver the guide extension, and then it made very easy to deliver the stent without traumatizing the stent on the way down. And then we, after the first stent, drive your guide extension inside the stent. And now she's going to go with a bigger NC, post-delete that stent, and then we'll deliver the second stent.
Maybe we should, do you want to IVUS for the length or are you confident
No,
the second stent length?
I
What
think
is it?
from the first pullback, we've probably got enough. And we can also, if you want, use this balloon as a second check.
So you're going to use a 38 here, guys? So you got 70 millimeters.
I
You
think,
put a 32.
I think it's going to be 30 or 40.
Yeah. Yeah.
So you had 71 millimeters, so you're just there if you put a 38.
They've gone a bit further than
Carried
they-
a 3.
I think they did go a bit
Yeah.
further, which I think is
you're gonna
good.
need I think you'll need a 48 here.
I think you will as well.
You went quite a bit beyond where the IVUS was.
Yeah, we did that deliberately, Jonathan.
Yeah, no, it's very nice. I mean, it's lovely delivery.
Yeah, but it's very difficult to understand the exact length in the absence of co-reg, which is a big weakness in the Boston IVUS at the moment.
The other thing is,
That's coming though, I hope. Is
It's coming, yeah.
this is an important point when you're doing long segments of IVUS. So you remember the artery slides over the IVUS catheter. So it's like taking 2 steps forward and 2 inches back. And so you will tend to elongate your length when you do a long IVUS run compared to if you do a short.
Okay.
Yeah.
Yeah.
Because this doesn't look like 48 to me.
Right, exactly. I think it's probably going to be 35-ish.
Yeah.
That's a great
It's
point.
going to be 42, I think.
And I would be redoing the IVUS here because I wouldn't want to put it 48 and have a
Have a bit sticking out.
sticking out into the
Check on
aorta.
here, please.
So that's a 15, so I think you're just touching the other stent there, Claudia, aren't you?
Yeah, so there's no way it's 48, Margaret.
It's gonna
There's
be-
probably, yeah, it's not. So it's maybe 38.
38.
That's a great.
Yeah, I mean,
That's
I
to your
think this is
point,
a 38
That's a
based
great
on your
idea.
previous
Why don't you
IVUS.
IVUS and just show us?
Yeah, we could re-IVUS, yeah.
Yeah, please. It'd be interesting to see
Yeah.
the distal vet.
I think you just saw a hand there because
Yeah.
the pulse pressure got a bit low. And
Yeah.
just
That's-
Yeah,
but
yeah.
he'll be
I've
all
backed
right.
everything out again.
Yeah, he'll be all right.
Just speaking about length, that's one
what
of
do you
the
wanna do?
advantages to the
Another
OCT is because the pullback is so fast,
Oh,
you
that's
don't
what-
have
sorry.
the
Let's
elongation
just
because
do
you
it.
don't have the 2 steps forward, 1 step back.
Yep. This
The
is
next
3.
pullback's going to be 8 millimeters a second, I think, isn't it? The
Yeah,
next
the
iteration. Yeah.
the fastest is
The IVUS again, please.
1 second for 10 millimeters, or 10
Take a little
centimeters.
puff here.
Yeah, that's pretty fast.
And
What's
another.
been the experience with imaging with these? What's the sort of deep OCT system? What's
Yeah, I mean, it's preliminary. We've done 25 cases. SpectraWave is now FDA approved.
Right.
Exquisite image quality. 1.1 second pullback for 10 centimeters.
right?
So it really revolutionizes saline guided PCI rather than using contrast. And then if you are going to use contrast, you need 3 or 4 mils because it's a 1 second pullback. And the resolution, I mean, after, I don't know, reviewing 20,000 OCTs, there's stuff on those, I don't even know what it is. So it's an exciting time for imaging. There's a lot of kind of good data coming up and then also newer technology.
Yeah, and it's all happening because, you know, we're putting the bricks in place to try to build that push towards fundamental ways of doing PCI, not this random, I just do this, I do that, but this is a systematic way of giving standardized care to people.
I mean, for Rob and I in the US, with the appropriate use criteria really changed this a lot because you can't stent a type A lesion. So you just get them when they're 8 years older with a CTO and multivessel disease.
No, it's true.
right?
It's true.
That's what you get now.
Yeah, I mean, it's really by default. You know, you really can't be an operator anymore and not use these techniques just because of the disease has
Maybe,
changed so
yeah.
much.
Take the balloon into the
This IVUS
stent
is
and
just
then
every time it's
And that's really, I think, where
I think you can be pragmatic here as well, though, can't you?
Yeah, so we're just saying if the IVUS, it's going now. If it doesn't, so we're just saying we've slightly changed the behavior of the vessel with the after stenting and probably further
Less
modification of the upstream calcium. Yeah.
And then, of course, the
So-
physics of this is you have these calcium, now it's all fractured and broken in all directions,
You're
and the
gonna hit
IVUS
them
catheter
all
just
down.
hits it in
In the
whatever
steps.
bias
Just
Just
it's
do
going
it
to
from there if
do.
we're doing it
Okay.
to length.
Okay, we're going to go from here and get proximal length measurement.
Great.
That's us in the front end of the other stent.
Yeah.
Let's see.
did
So
you
the
take
front
that up
end
with a
looks very
3.5
good.
or
Yeah. Yeah.
Yeah.
Yep.
okay?
Another
Craigie.
Slit.
There's your flap.
Lovely
Nice
picture. that.
fractures.
it's great.
Lovely. No.
Here.
Okay, another 2,000.
Yeah, that looks
It's going to be a
pretty good.
38.
Yeah. Let's go to, yeah, there we go.
So what do we think?
I think you have to take a 48.
48.
So do I, so we can pop
Or-
properly?
Really?
I would 38 and use a semi-compliant
Yeah,
or
me
a
too.
low-pressure balloon in the left
Me
main
too.
just to push the struts out of the
okay.
way.
too.
So you're going to have the proximal edge of the stent over the circ, aren't you? So with more struts.
Well,
over the circ.
and what's the gap between that and the ostium? It looks like there's still 4 millimeters there.
Maybe mark the
So-
ostium of the
So
LED.
the ostium of the circ,
Okay, yeah.
Navalia, so
Well,
you
move the
go-
distal end in a bit. Maybe you will
Yeah,
get
you've got
the
loads
38.
of space there, haven't you?
Move
Keep
the
going, keep going.
there's the circ there.
Yeah.
I mean, there is
okay.
distal left main, isn't there?
I would use a 6 millimeter balloon if you have it for pot here and be good.
Yeah, and,
We do, yeah.
Let's not. If you have to pot the proximal left main stent, you have to come proximal to it.
You really
It's
do.
very difficult not to come proximal to it.
You really do.
So you just go low
John, you go
pressure.
48?
Yeah.
I go
45,
48 and have
48
just
and a 6 overlap.
more overlap.
I mean, stenting to the ostium.
Yeah, you
in
got
this
at least
situation.
4 millimeters overlap,
Yeah.
which is a nidus for stent failure, isn't it?
Yeah. You don't.
And you've also got the ostium of the left main to deal with, which you don't need to really. But
No.
So if we have any problems getting this down,
4
even with the guide
millimetre, sure.
extension, we can re-deliver the balloon and track the guide extension back in if we need to.
yeah, it's just
And this is what we saw, with the whole, should I take my guide extension out,
Well,
wire
I
the
could just do
circ?
that.
It's like we saw how
There it
difficult the
goes.
IVUS
Well
was,
done.
we don't.
Well done.
yeah. Take
Well
your guide
done.
extension out, and you're in a
That's
world of
funny.
pain there.
You're just, starting over.
I think it
Gone
jumped
there.
forward then.
There it goes,
Jumped
yeah.
over.
Yeah,
Well
there we
done.
go.
There you go. It's probably because of that
Okay,
NC.
so guide
Honestly, good move
extension
on that.
back, guide in.
This is 38 as well, just for Jonathan's sake
Yeah, yeah.
here.
Okay.
So he's missing 10 millimeters of stent here.
So we're going
Yeah.
to back up till we minimise our overlap and then just check where we land.
It's the subplot of the calcium masterclass. That's most interesting.
That's good.
Just out again.
Okay. Just one touch.
Looks like you're
Yeah,
jinxed in it, are you?
you're short distally.
Just kind of a button, kind of beat.
Yeah.
Yes.
There you go.
Maybe it's okay.
You might not be able to see the stent boost.
There you
That's
go.
what I'm doing here.
Oh, do you have the boost? Oh, yeah, we
You have
can
the
see the
boost.
boost.
If you're in the
Lovely.
bottom-
If you go
Yeah,
There we
that's
go.
good.
That's nice.
Good,
isn't it?
good.
Okay, so
Yeah.
now
Just
we'll
checking the
check.
spider, please.
Lovely.
Look at that
Yeah.
proximal
Yeah.
calcium.
Look at the calcium in the
I'm
left
trying.
main.
Yeah, that's crazy.
Yeah.
It shows us where the left main body is. Nice.
Yeah, the LA crane. will
The
show you.
left main that we've just described as completely free of disease, that left
Interesting.
main. Just use your guide extension for any contrast here.
Yeah.
Squeak it in there just a tidge.
There you go.
Give a wee test.
Yep.
Ready?
Just a squeak.
That's good.
Yeah.
Across the circ, certainly.
Definitely
Yeah,
needs
that's nice.
another 10
We
millimeters
can check
of
though.
stent there.
So let's go cranial and just check
Yeah,
we're still
just-
overlap.
Yeah, that LA crane and just see where
Heavy,
it
that.
lands compared to the ostia.
Even if it's a
You happy?
butting.
Yeah.
Looks grand there.
You've got-
I mean,
you've
you've
got
got to
enough
take that,
coverage.
haven't you?
Yeah. I think it's.
Yeah, perfect.
Yep. All
So
right.
just do the
Looks
guide
good.
extension
Yep.
back from the front. Look at that,
Puddle
nice.
doesn't always show you the nose, sometimes of it just kind of lipping out, so it's really nice to see the cranial.
Good.
Very nice. Very
That's
nice.
great.
Okay, so we're going to be very careful now with the front of that stent because it's floating, yeah?
Put your guide extension in it and you'll be happy.
You
won't
just
you?
very
take your
carefully
time with
track
that
over the
balloon
balloon.
deflating.
Just
And,
gonna-
yeah. And I will
There we
typically
go,
back
nice.
my. Okay.
That's lovely.
Okay.
So we'll do the pop first. Although we're now in a strong position that we could just postulate all of that and back up if
Okay.
you want.
Yeah.
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 But just remembering your guide can still cause, even though the guide extension's in, the guide can still have fun.
That's
So which
interesting,
one's
isn't
the
it?
front
'Cause
box
of
LED
course it
for?
still
Right,
can.
yeah,
can't
for
it?
15
Yeah,
NC.
absolutely.
Just have to be. I only know because I've done it myself many times around the IVUS back. And
Guilty.
just sort of look up at the ceiling like, why?
Because we use so much device detection.
Yeah.
So I'm
Yeah,
like,
it's just-
I swear I put more left main stent in there. Oh, that's why.
Yeah.
It's now, yeah.
We covered the
It's now a
ostium
Fox LED
clearly,
stent.
right? I
Nailed
see.
the ostium.
Right. Yeah.
It's all the physics of the catheter, isn't it?
Yeah, well done. Well done.
I don't think it's. I think it's just this IVUS catheter's on its last legs.
worked
So.
hard.
Yeah.
Yeah,
tired.
there's a few bends in the back end of that IVUS catheter, I assume.
Yeah.
Oh, you can
Don't
see
get
that,
some?
can you? I thought-
Oh no, I've just done it enough times to know that you've made yourself probably a hand grip at this point with the back end of the
So
Maybe go live on
what
that.
made you guys choose IVUS over OCT? Was it the GFR? Was it the patient age? And it might just be preference.
You're making Ziad a bit upset, so if we
no.
could just talk about
I'll
that.
let that Claudia answer and then I'll tell you why for me.
Yeah, I mean, I think both those things, the renal function, I think initially there were some really severe stenoses that might have had trouble with clearance with the OCT, and then just when intending to come back to the left main to be able to hang the guide out. But I think OCT would have also been really helpful there.
Yeah.
So I think there's two specific advantages in this patient to OCT. I mean, I'm not surprised. You're not surprised I'm saying that. But the main feature is it does allow you to differentiate between eruptive nodule and protruding nodule, which actually has some clinical implication. And the second thing is just so easy to see the fractures.
Yeah, absolutely.
Right.
No doubt about that.
Yeah.
But having said that, with this HDI versus, it's been beautiful imaging. I think.
Yeah, absolutely. We've seen what we need to see. And, you guys have illustrated how modern PCI, the contrast use is so different, right? Using imaging to guide everything. This has been, not a long case, but not a short case, and we've really used very little contrast because we've used the imaging. You guys
Very
have
little.
demonstrated that
7
really
runs.
well.
Yeah.
Really, really well.
How much contrast have we used?
Say a small number.
Yeah, just 12 is fine. Just say 12.
As it's coming across the circ.
That's nice.
It's
And there's a lot to talk
That's
about.
perfect.
We can go back over this
beautiful.
iris.
Nice job,
But there's a
guys.
lot to talk about.
Okay,
80.
brilliant.
I'll go back.
Really nice.
Little bit of maybe post-optimization
there were
at the
few-
end, but otherwise,
There are a few little bits that I thought looked a bit underdone. Maybe the distal part, we hadn't post-dilated very distally. It's-
Yeah. Distally, I would say, is about the only bit, Claudia. I mean, it looks great proximally and so on.
I'd be post-optimizing with a perclose.
Are they radial?
But not by the radial,
Yeah, I was like, do you want to talk me through that real quick?
That's the US bias again.
Just talk me
Just
through.
run
Just talk
through
me
this
through it real
again. Just show us the distal edge of the stent and then the expansion of that distal segment. I think that's the only bit.
This ledge is perfect there,
Yeah.
not it?
Yeah, it's nice.
Yeah.
Happy with that?
Yeah.
Definitely, yeah.
That's a classic. So you've
just the
deformed
nodule,
the
isn't it?
nodule,
Yeah.
but the nodule's deformed, and that's the key.
And you've
So
got a good
You can see it as a big
We're gonna-
circle
yeah.
on top
Yeah.
there.
we're
can't
going to
you?
talk about that a little bit later on the
give us what you
deformability and the eccentricity.
You can also see a bit of penetration into the nodule there
Yeah.
as well,
Yeah,
which
that's
suggests some disruption,
crack
which
there,
is
yeah.
It
interesting.
was really nice there just to see that, yeah.
So
6.3.
6.4 down there is pretty good.
Terrible for them.
Yeah, it's pretty good, yeah. And you haven't done a post-dill in this area, I think. Is that what you were saying?
No, I'm just going to take a 3 ONC down here now.
But honestly,
That's
But an
Similar sort of
MSA of
deformed appearance.
6.35
Right. I mean-
is, I think, actually very acceptable. So
Yeah.
let's see what this is.
Yeah, I'm not going to go
Similar.
too high.
meaning you'd be okay to go for your radial perclose at this point.
I think still, and again, 6 millimeters squared in this
Just go
region
down
is
to 12.
Done a
Yeah, so the classic situation with the good area, adequate area, but
Yeah.
eccentric expansion.
yeah,
No,
partially
music
deformed
criteria and
nodule,
everything
back
else
to
is quite
concentric
good,
again. So, I mean, it's been really fascinating case with all these different morphologies and technical challenges. You've done
Really,
great.
really good case.
Well chosen.
Well chosen. That's right.
We have to look really hard to find calcium here in South London. So,
Down. Margaret, is there anywhere else you've spotted that needs some post-dilatation?
The areas all look quite good. So here's us round about
Nine,
the
yeah,
kind
brilliant.
of
Just-
That's nice.
aneurysmal area. 9.
Yeah.
So I think you can complain about that.
no.
just really the ostium of the LAD is.
Yeah, let's see what we
Yeah.
think about that
Yeah.
as we come
It-
through.
It was underdone on the stent expansion. So we'll see what it is. You could see the nodule coming in then.
Here.
No, it's
That looks great.
still not bad though.
Yeah.
Still not bad.
It's really
It's just again,
gonna
it's
be
another
10
D-shaped
something.
stent, but it's looks good area.
very good.
Yeah, I think it's pretty good. Eh?
That's pretty respectable.
Yeah.
Beautiful. Well done. Well
So
done.
somewhere around about 11.5, 12
Yeah.
for the osteum.
So time for a final angiogram, because I think Claudia has been post-dilating whilst you've been walking us through this IVUS, Margaret.
Yeah, and the front end of the stem looks perfect. Eh?
Perfect,
Transitions
perfect.
really nicely.
Perfect.
Lovely.
Great.
Certainly we're getting the top tertile and excel, this one's here, eh?
Yep.
Ready for picture?
That looks great. And
Just do a spider.
and that we talked a little bit about the diag as well proximally, and we elected not to sacrifice our guide extension use to have a wire in that either, and that's held on
Yeah.
really nicely. The osteum looked healthy.
Yeah.
Just give us another view just so we can see the
There you go.
osteal segment.
Sac's a bit pinched, but
It's just a shift in the carina,
Yeah.
isn't it? I mean, so sometimes what I do in this situation, if I'm at all concerned, is I wire the circ and just stick the IVUS in and measure the area of the osteum. And you can usually almost always do it without actually even having to disrupt the struts. So that's something that we could consider. The other thing we talked about at the start of the case was that intermediate vessel, which again is we haven't compromised. So that's great.
yes,
Fantastic
I was a
result.
bit worried
Claudia.
about that.
I mean, let's not forget this guy is nearly 90 as well,
Exactly.
Yep.
and he's already
Exactly.
done incredibly well in this case. So I think,
Exactly. You always
a
make
great
these
job.
decisions in the context of the greater patient. Yeah.
of course, definitely, yeah,
Okay, should we leave it there?
Yeah.
Yeah.
So
brilliant.
I think we're done, Claudia.
Yeah, I think so. I think that's a good result for him.
Yeah, congratulations, both of you.
Fantastic
Great,
job.
Well done.
great case,
Right.
great presentation, and a real triumph of demonstrating what can be achieved in really challenging calcific disease. You left nothing on the table there, so congrats to both, and thanks to the patients and the team for supporting.
Wonderful case,
Yep.
guys. Great job.
Great job.
Thanks, guys, and thanks to the team here. Done a great job.
Thanks to Margaret and Claudia for a great case, and that's all we have time for today. Thank you all for joining us here. As ever, all the classes and additional learning resources are available now on the Shockwave Hub on the Wonder Medical site. Goodbye.
Bye-bye.
Goodbye.
Bye.